Imaging of the GI tract today, and then we're going to follow that with our imaging of the GU today, okay? So as we discussed yesterday, three parts of the stomach, the fundus, the body, and the pylorus. So beginning at the pyloric valve of the stomach, which is the valve or sphincter that connects the stomach to the first part of the small intestine, which is the duodenum, which is the shortest and the widest. Following the duodenum, we have the jejunum, which connects to the duodenum at what is called the DJJ, or the duodenojejunal junction, okay? Say that 5 times fast. The jejunum makes up about 2/5 of the intestine after the duodenum, okay? After the jejunum, we have the ileum, spelled with an E, if it helps you remember. When we're talking about the small intestines, we use the word entero, right? It begins with an E. So the ileum of the small intestine has an E in it. It makes up the rest of the small intestine. The ileum is the longest portion of the small intestine, makes up the last 3/5, and it connects to the large intestine at the ileocecal or IC valve, okay? The jejunum on imaging has what every textbook you will ever read and people that you meet say has a somewhat feathery appearance. It just looks a little fluffy and floaty. I don't know what they mean by feathery, but it has a feathery appearance. Following the small intestine, we have the large intestine, which is composed of 4 main parts, beginning most proximally at the cecum, which is then connected to the ascending colon, which is then connected to the hepatic flexure or right colic flexure, which is then connected to the transverse colon, which is then connected to the splenic or left colic flexure, then connected to the descending colon, then the sigmoid colon, and the rectum, and finally the anus, okay? The large intestine and the colon are not synonyms. The colon consists of the ascending, transverse, descending, and sigmoid colon and their flexures. That's just for you to know. Similar to our discussion of the stomach and knowing what body position is going to put the contrast where, we need to have the same knowledge about the contrast in the large intestine as well, okay? So if the patient is supine, we have the ascending and descending colons on the lateral aspects of the abdomen, and the barium will fall into those most dependent areas, okay? If the patient is prone, then the contrast is going to flow into the dependent areas in that position, which would be the transverse colon, and the sigmoid colon, okay? Questions so far? April, you look like a deer in headlights.
There's just a whole lot of colon.
You look like a doctor standing in the door. I was like, yes, sir, can I help you? You got a case? Okay, so the study that we do to evaluate the small intestine is called a UGI-SBFT. UGI, small bowel follow-through, okay? Usually a small bowel follow-through follows an upper GI, okay? We never really do the small bowel follow-through without having done the upper GI. It just makes sense to do that because if you do the upper GI, you might as well follow it the rest of the way through instead of having them come back another day just for the small intestines. Make sense? So we're going to do the routine upper GI series. Patient should have ingested 1 whole cup of barium or 8 ounces, and we're going to note the time of their completion of that first cup. After the radiologist does his fluoroscopic examination and we do our radiographic overheads if we need them of the stomach, then the patient is going to be given 1 more additional cup of barium to ingest, and we're going to note the time of their completion of that ingestion as well, okay? Then begins the timer for us to follow through the barium, okay? So 30 minutes after the initial ingestion of barium, we're going to take a PA radiograph of the proximal small bowel. Why PA? Why not AP? Critical thinking skills are hard at 8 o'clock in the morning. Sorry?
Where it rises to the...
All right. We're going to use the compression of the patient lying on their abdomen to help separate some of those bowel loops. Okay? So lying on their stomach helps to kind of separate the bowel loops a little bit. Half an hour interval radiographs are going to be continued until the contrast has reached the ileocecal valve or the TI, which is also the terminal ileum. Okay? Questions? Anything to add? No? Okay.
So the barium actually separates that stuff in your stomach?
No.
Okay, so
You're separating the loops of bowel. That pressure is
Uh-huh.
helping those bowel loops that are kind of like this in your abdomen separate a little bit so you can see them easier.
Mhm.
Make sense?
Mhm.
Questions? Okay. Great. Let me slide on to my next page. Small bowel series. This is, I guess, if you were to do just the small bowel follow through without the upper GI. I've never done that in my time, but if you were going to do that, you would give them 2 cups of barium, and you would note the time that they were finished. First radiograph would be taken 15 to 30 minutes after the completion of the barium. The first radiograph will require higher centering, so you're going to center about 2 inches above the crest for that first image only. After that, the half-hour radiographs will be centered at the crest, which makes them what? What abdominal radiographs are centered at the crest? Yes, KUBs, until the barium reaches the ileocecal valve. Okay? Most of the time, well, sometimes, if you're in an adult hospital, the radiologist will want to know when the contrast has reached the terminal ileum so they can come in and do what's called spotting the TI. They will take that compression paddle and apply pressure to the patient's abdomen and separate the bowel loop so they can see that point where the ileum reaches or is connected to the cecum. Okay?
I have a quick question.
Yeah.
Okay, so radiographs as in overhead radiographs?
Yes.
Because there are also is the other machine. So this
Which is what other
the
machine?
Did
I say fluoroscopy?
No, I'm just making sure.
Radiographs.
Okay, I'm making sure
Yes.
because there's a lot going on.
Radiographs.
Got it.
Enteroclysis, double contrast small bowel procedure. We actually place a tube through their nose all the way, well, it doesn't necessarily have to be through their nose, but we place a tube through the stomach into the duodenum to the region of the duodenojejunal junction. I knew I was going to trip up on that. The duodenojejunal junction is held in place by something called the ligament of Treitz. Okay? Basically what we're doing is bypassing having the patient drink or eat anything, and we're just injecting the contrast directly into their small bowel. Okay? Patient still needs to be NPO for at least 8 hours for that procedure. Okay? Questions? Questions?
I'm not going to ask a question.
And you're welcome to.
No. I was just making sure because yesterday it was like 2 steps. This is just solo.
So this is not solo, but I understand why you would think that. So we're following the upper GI. So we did the upper GI yesterday. The small bowel comes after that.
So it can be done at the same time. So then now we're doing this.
So the radiologist
Already left.
You're asking a good question, okay? So please feel free to ask questions. We do the upper GI, the radiologist does his fluoroscopic part. Then we move this back. The small bowel portion is mostly radiographs.
Okay.
The radiologist is not going to use fluoroscopy for that, except if he wants to spot the TI. Make sense?
Whatever TI is, but yes.
Terminal ileum.
Okay, gotcha.
Great. Okay, any questions on the small bowel procedure? Okay. Now we're going to talk about the barium enema. Yay, everybody's favorite. I remember whenever my instructor mentioned that we were going to have to do barium enemas, I had no idea that that was a part of what we do.
It is what it is.
Exciting.
Fun.
So the barium enema, also called the BE, is the study that we use to radiographically evaluate the large intestine, okay? We study the form and function of the large intestine, basically to detect any abnormal conditions. We do this often. In a pediatric environment, we're looking for some kind of congenital abnormality with their large intestine. If it's an adult, it's probably going to be to evaluate for some kind of cancer. Okay? It's very important to review the patient's chart if they had some kind of a scope procedure recently, sigmoidoscopy or colonoscopy, because we, again, don't want to give barium to somebody who may have a perforation, and the colonoscopy could have caused a perforation, theoretically. Okay? So if they have had a sigmoidoscopy or colonoscopy, we're going to let the radiologist know before we even get started or set up with anything. Okay? There are two classes of laxatives that are used to help patients get prepared for a BE. If you ever talk to a patient who has had a barium enema, they will tell you how intense the prep is for a barium enema. It is laxatives, it is enemas, cleansing enemas. It is like they have to drink a whole gallon of like laxative to clear their bowel so that we can get a very clean large intestine for their study, okay? Because if there's any poo-poo left in the large intestine, what's that going to do? Well, that, but also it's going to look like something. It's going to look like maybe something abnormal, okay? So, two classes, castor oil, saline laxatives. I'm going to make sure that bowel is nice and clean and clear of poo-poo. I like to say poo-poo like that, it's funny. Contraindications for barium enema. Perforation. Obviously, we don't want to use barium anytime that there's a risk of some kind of perforation of the GI tract. Possible large bowel obstruction. If a patient has a large bowel obstruction, we definitely don't want to put barium in there to make the issue worse, okay? Their bowel would suck up all the water and they would be left with even more of an obstruction, okay?
So does that clear with CT as well?
Sorry?
When you said yesterday about being cleared with CT, would this be the same kind of incidence or no? Or situation?
I'm not sure.
Because you can't get a CT with contrast if you're doing any of these studies with contrast. It will show, like if they got a CT with contrast, they can't do this exam.
Okay, so the same question would apply, like if it's cleared CT or done a CT contrast before this?
We would probably have looked at their history to know that. Yeah.
Okay, so it would be.
But you still need to wait some time for that contrast to clear if they drink
So
contrast.
same contrast for any of this kind of stuff.
Yeah.
Typically your front desk is managing this. They'll be like, no, they'll schedule, because this is all scheduled. So,
Oh, okay.
Yeah.
Okay.
This is typically not a walk-in.
No.
Yeah. Okay.
In a pediatric environment, a BE can be an emergency thing.
Okay.
But we're not going to talk about that now.
Okay.
But for an adult, it's routine.
Okay.
The other main reason why we don't want to give them contrast if they have a large bowel obstruction is we could cause a perforation. If they have a large bowel obstruction, we start putting stuff in there into an obstruction. There's only so much pressure that can take before something has to give somewhere. Okay? So, in the case where we're concerned that there could be a perforated hollow viscus, we're going to use iodinated contrast media again. Okay? Very important to let the radiologist know, again, if the patient had some kind of a scope procedure recently, or if a biopsy was performed, okay? The equipment and supplies. We're going to use a closed system, thank God, because you don't want any part of this system open for this procedure. You know what I mean? Because you're going to get poo-poo on you, cat. That's what I mean, okay? A closed system enema container is used to administer the barium sulfate or an air and barium sulfate combination. So you can do single contrast, BE, or double contrast. Okay, single contrast, again, same rules. Single contrast is going to show the shape. Double contrast is going to show if there are any polyps or lesions inside the mucosa of the large intestine. Okay? We're going to use an IV pole to hang the enema bag. Don't hang it any higher than 18 to 24 inches above the tabletop. Okay? Enema tips. It comes with a plastic disposable tip. And if I were getting an enema, I would not want the plastic disposable tip. It is very rigid, it is very hard, it's very sharp. So a lot of departments that I've worked in have actually not had us use the tip that comes with it, okay? We use one that's softer like this, okay? Rectal retention tip, that's what this one is. So this one doesn't have a retention balloon on it, so you would probably have to tape this one in. But this one does have a retention balloon on it. Wow. The balloon helps keep the tube in and also helps keep what, Kat? The poo-poo in. Exactly.
But there shouldn't be any.
There shouldn't be, but it's the barium poo-poo. And the air contrast retention enema tips. I'm glad Mr. Ubaldi let us know that they are all intended for single use. So please don't try to reuse the enema tip for all of your BE patients.
That's very important.
For the So this would be one that you would use for double contrast BE. Okay, you could use it for either, but you can also use it for double contrast. Okay, we're going to insert it. We're going to inflate the balloon to keep it in. And then during the procedure, the radiologist is going to open this to let the barium flow in. Once he's satisfied with the amount of barium that's in there, he's going to close that off. And then if he wants to give that double contrast effect, he's going to insufflate some air as well. Okay? And when they do that, usually the patient goes, oh! It's very uncomfortable.
So the radiologist is the one doing this procedure as well?
Yeah. The radiologist is mainly responsible for a lot of the manipulations for a BE because of the risk of perforation. So they're going to control how much barium goes in, either by doing it themselves or by letting you know, turn it on, turn it off, and they're going to control this, the amount of air that they put in. Okay?
Anything with fluoro, the doctor has to be present. We do not just do fluoro on our own without anybody, not a doctor, radiologist.
Unless you're scanning the lead.
In California, it is illegal.
No.
And then also, oh shoot, never mind. Oh, when I remember.
All right, questions on any of that?
Oh, I remember now. The double, when you said you can use single contrast or double contrast, that would be also ordered, directed from the doctor, right?
Yeah.
He would tell you.
It would there would be
kind of
whatever the history of the patient is going to be the indication. Yeah. For the insertion of the tip, maybe this is the next page. This is the most involved, or one of the most involved procedures that we do in fluoroscopy. Okay, so when you're preparing this, when you're mixing up your barium, you want to use room temperature water or just a little warmer. Never use hot water. Ow. Okay? A lot of people like to drink their coffee. They don't want it as an enema. You know what I mean? So we're never going to use hot water, room temperature, or maybe just a little warmer because we don't want to scald the mucosa. Okay? We also, if you use cold water, it can cause a lot of spasming and it's very uncomfortable for the patient. Okay? So set up, we're going to have the patient change into a hospital gown. Take off absolutely everything. Remove their underwear before the start of the procedure. We're going to take a scout abdomen x-ray to see if the patient followed the prep instructions. Okay? So we're going to do a KUB of their abdomen to see if they have retained any what? Poo-poo! Exactly. The patient is then going to be placed into the Sims position. Do we remember the Sims position? It's the recovery position, but basically lying on their side with their right leg bent up toward their chest, okay? They're going to be asked to roll onto their left side and lean slightly forward. The right leg, again, is flexed at the knee and the hip, basically the knee is brought up toward the chest, okay? This position relaxes the abdominal muscles and decreases the pressure within the abdomen, okay? Patients should be told to keep their anal sphincter tightly contracted. That is a terrible sentence. Basically, the long or short of it is that once we lubricate this tip and insert it about 3 to 5 centimeters, we want it to stay in, and we need their help to keep it in, okay? So they're going to feel a lot of pressure. They're going to feel like they need to bear down to, as my grandfather used to say, move their bowels, but they need to try to keep the tip in, okay? It's going to help get the procedure over quickly and prevent a huge mess on your table, okay? They're going to relax their abdominal muscles during the procedure to prevent increased intra-abdominal pressure. The BE is an uncomfortable procedure, period. It is. We're putting a bag full of fluid into their abdomen, and we're also giving them gas sometimes. they feel a lot of pressure in their abdomen, and they will probably complain about the discomfort the entire time. So, as with every other procedure, but especially for the BE, our job is what? Communication, patient comfort, okay? You're going to be fine. We're almost done. We're just getting a few more pictures, whatever. Just engage with them, try to keep them calm, because if they get anxious and they start tightening up, it's more uncomfortable, okay? So ask them to concentrate on breathing by mouth to reduce spasming and cramping, okay? For the enema tip insertion, the patient should be, again, in the Sims position. They should be relaxed prior to the tip insertion. They shouldn't be like, oh my God, right? We need everything nice and chill. The tip should never be forced in a manner that should cause injury to the patient. The abdominal muscles should relax on expiration. So before you insert this, when you've got them in the Sims position, you've got your lubricant on the end here, you're going to say, okay, I'm about to insert the tip. Take a deep breath, blow that breath all the way out. As they're exhaling, you're going to insert the tip, okay? For patient comfort.
So like a thermometer with the baby?
Kind of, sort of.
In some sense.
Yes.
Okay.
The tip should be aimed toward the umbilicus, okay? So you're going to basically go like that, okay? The rectal tube is directed superiorly and slightly anteriorly to follow the curve of the rectum. And the total insertion of the tip should not exceed 3 to 4 centimeters, so about 2 inches, okay? 1.5 inches, 2 inches. The IV pole, again, should be no higher than 24 inches above the tabletop, okay? Questions on any of that? Yeah. Yes.
Say the tip pops out like halfway through the exam.
Yeah.
What's like the procedure after that?
Everything stops because you probably got a huge pool of barium on your table. And anywhere where there is barium on the sheets, on the patient, on their gown, is going to show up as a radiopaque object, right? So now we have to strip the patient down, give them a wet towel to clean up. We have to clean everything off the table, reset, and start over.
But that shouldn't happen. Like if you do it well and you should make sure everything is set
Yeah.
before the doctor even comes in. And the balloon is working, no cause or anything. It shouldn't happen.
I've had it happen one time.
Where it came out?
Yeah. I had it happen. Did I tell you guys this story? I thought I told you this story. My old man, it's because he was old, right? So he couldn't really hold it in. Now he was, really sad. He lost it. Martha went, clean up, and left. And I was there cleaning barium. Okay, so summary of enema tip insertion procedure. We're going to describe the tip insertion to the patient. We're not just going to do it. Hi, surprise! We're going to tell them what's happening. Answer any questions. This can be a very sensitive and kind of scary thing, right? We want to tell them everything that they're going to feel, everything they're going to experience. First, they're going to feel a little cold as we put the water-based lubricant on the outside of their body, right? They're going to feel that. Then they're going to feel a little pressure as we insert the tip, okay?
So do you explain before the patient lays down in position, do you kind of give them a breakdown and step by step that
Yeah.
you're going to explain it step by step as
Yeah.
it goes? Okay.
Yeah,
I mean, they're
absolutely.
going to the restroom as well. So when you bring them in, you explain it to them, tell them to change, and then you get them.
Okay.
Also show them the tip. Like tell them this is what's gonna
Yeah.
happen.
And tell them how much. So we're going to use this tip, and I kid you not, I know it's happened to you too. I show it to the patient. That whole thing's going in? About that much. Okay?
Show them the balloon.
Got this every single time. I got that question. That whole thing? Or this? They're like, that? The whole thing? Yes, the bag will be hanging out of your butt. Going all the way to the hilt. Place the patient in the Sims position, okay? Shake the enema bag one more time to make sure that it's completely mixed, okay? We don't want to have a glob of unmixed barium go in. So shake the enema bag, allow the barium to follow through the tubing. When you're setting this up, when you've got your barium in your bag, this is all going to be clamped off, okay? Because obviously you don't want to have this spill all over your floor. But before you bring the patient in, you want to unclamp it and let it run as close to the tip as possible, because we don't want a whole line full of air going in before the barium goes in. Okay? Wearing gloves, please, the whole time. Wearing gloves, coat the enema tip with water-soluble lubricant, and then you're going to you're going to tell the patient that this is what's coming, what they're going to feel, and tell them to take a deep breath, and then gently insert the tip toward the umbilicus, about 1.5 inches. Okay? After the initial insertion, advance the tip up superiorly and slightly anteriorly, again toward the umbilicus. Total insertion, again, should not exceed 3 to 4 centimeters. Okay? If you're not, most places will not be the one responsible for inflating the balloon. Again, this is a safety thing. We don't want to have you insert the tip and then inflate the balloon in the wrong place and hurt the patient. So typically what we do is we insert the tube and we tape it in place to prevent slippage until the radiologist comes in and they inflate the balloon. Okay? But we don't inflate it typically. There are some places where you can. It just depends on where you work. Okay? Ensure that the IV bag is no higher than 24 inches above the table. And be prepared for leakage. Whee! Exactly what it sounds like. So have plenty of towels and sheets and gowns. Have a crucifix. Okay? Types of lower GI exams. Again, we do the single contrast barium enema, double contrast, evacuative proctography or defecography. Thank God is not done that often anymore, but there are places that still do it. You literally will inject very dense barium into their rectum and have the patient sit on a toilet, and we will take radiographs while they poo-poo. Yeah.
That's wild. I am not being paid for that. I'm calling.
Okay, questions? So again, in review for your small bowel series, the first image you're going to take is going to be 2 inches above the iliac crest after they finish their first cups of barium. Okay? 2 inches above, and then after that, we do it at the crest. Okay? And again, the exam is completed once the barium reaches the terminal ileum. For the barium enema, the basic positions are PA and or AP, RAO, LAO, LPO, RPO, and lateral rectum, and PA or AP post-evac. What does that mean? So after the procedure is done, the radiologist has done his fluoroscopy, we've gotten our overhead images. Mind you, the whole time that we're taking our overheads, the patient is still full of this barium. So what is very important? Efficiency. We need to be very accurate with our imaging, okay? Because the whole time they're going to be on the table, okay? Lying on their back. So we need to be quick about what we do. Once we're done, this tip is still going to be in the patient. Okay, Mr. Happablap, almost done. I'm going to drop this bag down. And all of that's going to come out, and they're going to go, I feel so much better, okay? Once we have let as much of this barium run into the bag as possible, we're going to gently remove the tip, either by removing the tape or by deflating the balloon and gently pulling that tip out. We're then going to help the patient go to the restroom. Most fluoroscopy units or fluoroscopy rooms have a bathroom right there connected. I would say all of them do. And you're going to help them go to the bathroom and try to get as much of that barium out as they can. Then they're going to come back. They're going to lie flat for one more x-ray. That is the post-evac x-ray. Okay? This is our documentation to make sure that we didn't send them home with a gut full of barium. Okay? Yes?
When you're doing this, do you have to have like your PPE, like safety goggles and stuff like that?
I mean, you don't have to go that hard. You don't have to go that hard. Esther Yita's going to come in looking like RoboCop. No. No. But that said, they can get messy, so be prepared to change into the OR scrubs. They're OR scrubs. Oh, are they? Come on. That's a great joke. All right. Any questions on the BE?
Okay, now that we learned all that, based off of our test.
Yeah.
So that's just a lot. That's more than what this is kind of like. So how do we practice kind of this?
So for your practicing, you're going to be focusing on the exams that will be on your final. The rest of the exams that are on this list, you should know.
Okay.
Because there's a possibility that it could be in your clinical environment. Okay? Especially a lateral rectum. I don't know where it is, but they do that one a lot. Oftentimes radiologists will begin their fluoroscopy by looking at the lateral rectum, just because they want to see the initial filling and make sure that the tip is in the right place. Okay, questions? I know it sounds like a lot.
When does it not?
So the rest of the exams that are on this list, just be sure that you're familiar with them. Okay, there may be questions on your exam this week about them. They may come up in your clinicals, but they will not be on your positioning final. Okay? But you do have a few that are on your positioning final, and they're on that list of positions. They are the AP RPO. This is for showing contrast in the ascending and descending colon and demonstrating the left colic flexure, also known as the splenic flexure. Contrast in the ascending and descending colon and demonstrating the right colic flexure is AP and LPO. How do I want to explain this? For demonstrating the flexures, I use my hands. Again, I always love to use my hands. I cut my hands like this. These represent the flexures. If I want to see the right colic flexure open, I do an LPO. If I want to see the left colic flexure open, I do an RPO. Okay? And these are the rest of the lists, or the rest of the positions. Okay? So when you pull BE, you'll only have to do 2 of those, depending on which one it is. But you will need to know which positions are going to show the contrast as specified on the card. Okay? Questions? Okay, may I have a patient? Who did the bowel prep? Because we have to demonstrate the tip insertion today.
Definitely Chris. He was not here yesterday. I'm just kidding. Oh.
All right, we're not going to do the tip insertion. Obviously, guys, come on. Come on. All right, so let me have you lie flat on your back.
And which one are you doing first?
Just for demonstration purposes, I'm going to show you the small bowel follow-through images. They're very, very simple. So for the first one, 2 inches above, and she should be PA, but this is just for demonstration purposes here, okay? So if she was PA, 2 inches above for that initial image, okay? Afterwards, at the crest, okay? Wow, that's hard, right? My God. It's like that one clip from The Office. Okay, lower GI. Let's start out with the AP and the RPO. AP. Oh my God, so hard. RPO. Oh my God, so hard.
That's at the iliac still, right?
Mm-hmm. And then LPO would be the same thing. Other side. RAO, same thing. Just PA. Watch your head. Not too bad, right? The hardest thing about the BE is going to be understanding
And
the
explain
explanation.
this.
Yes. Question.
I might like you today.
Like for the final.
Sorry?
For the final, if it was just what you did, or how involved is it when you actually test?
So you would go get your mock patient and you would say, "Hi, Miss Majdalawi, are you here for a barium enema today?"
Yes.
Great. I'm going to be your technologist today. So what we're going to be doing is called a barium enema, as you already know. Basically what we're going to do is we're going to insert a small tip, just a little bit, about this much, into your rectum, and we're going to use that tip to put in this white liquid into your bowel, okay? While that barium is flowing into your bowel, the radiologist is going to be taking pictures, having you turn in different positions on the table. I'm going to be here to help you the entire time. Once the radiologist is done with his images, we're going to drop the bag, or I'm going to take my images, we're going to drop the bag, let that barium flow out, and then I'm going to take one more image. Probably the worst explanation possible. But during the procedure, you're going to be feeling a lot of pressure in your bowel, in your stomach. I just want you to try to breathe through that, breathe through your mouth so that you can keep everything nice and relaxed and prevent cramping in your stomach, okay? I will see if I can find something that's more succinct than what I just said. It's been a while since I've explained a BE, but I will give you guys a good tool.
Your bottom squeeze together and hold it in place.
So we're explaining the procedure, we're taking the x-rays.
For your
Yeah.
final? Yeah.
We're explaining, they were taking the x-rays,
Yes.
whatever we get on the card.
Yes.
So when they're flipping around and all that, you gotta keep this
Oh, yeah.
baby in.
So that means that you'll probably go from here to here. You're going to be very, very aware during a BE, because if their feet get caught up in that, no bueno.
Yeah. Okay.
Especially if the balloon is inflated. Oi! Know what I mean? Ah! Okay. Questions?
I don't know if that's a warning or like a trauma.
A little bit of column A, a little bit of column B. I will get you guys a better outline for a script, so you guys can use that, okay? Just takes a lot of practice in doing them. Even honestly, for me, I did most of the BEs or enemas that I did were on babies or children, and it's just a different process. So explaining for adults is something that I haven't done since I was an X-ray student, honestly. Okay? But I will make sure you guys get a good script to use.
More? Anything to add?
I've only done adults. Okay, so when they come in, they kind of already know what they're getting into. So I just explain again. I show them the tip. I tell them that, and everything's already ready. Contrast is in. I do equal amount of contrast to water. So if I put 1 bottle of contrast, 1 bottle of water. I have my table ready. The towels, everything is ready for them.
Chucks.
Chucks, yes, very important. Tape it down, make sure everything is good. I have their gown ready. I bring them in. I explain it to them. I show them the tip. I tell them that it's going to be a little bit of pressure in the beginning, but I'm going to be right here with you. It should be only about a 15-minute procedure once the doctor comes in. And then once we take that out, you're going to feel so much relief. Like, they get really happy once it's out.
Mhm.
Then everything is out, so they feel so much better. Usually they're coming in because they're constipated or because they haven't pooped in a week, so, or like more than a week, so they're gonna feel really good. It's all gonna be out. And then yeah, I get them into the bathroom. They change out, they come back to the table. I take my scouts, and then I turn them into position. I call the doctor. He comes in, he explains the procedure to the patient again, and then he begins, and then he's telling me what to do. And then he's telling me, drop it, whatever, and then he's gonna leave. I drop the bag, take it out, and then I have them go into the bathroom and clean themselves up. I give them time in the bathroom, like, because we, gotta everything out.
So when you drop the bag, that's when it goes off, is where you allow.
Yes, that's when you're gonna see everything rush into the bag.
Okay.
Yeah, because of gravity.
Yeah.
How many have you done? Oh, a lot. My hospital did it. There was like at least one every day. But it also depends on hospital. Like some hospitals I think don't even do that. Yeah.
Most people send them to, I think, CT now. They do CT
yeah.
colonography. Questions? And pediatric enemas are, honestly, I could do a pediatric enema all day. I hate adult enemas. They're messy. So much.
The preparation for you, just make sure you are masked up and then put some vapor rub under your nose and you can last all day. Take a breath every once in a while. Open the door. Close the door. Because it can get stinky in there.
Okay, so real quick, and this applies also to the upper GI, as we discussed yesterday. So single contrast versus double contrast. Single contrast for upper GI or enema is going to be looking for extrinsic problems, things that squeeze the colon from the outside or cause what's called a luminal narrowing, okay? Or maybe there's a twisting of the bowel, and we would see the contrast come to a point. Single contrast is going to show that. When we coat the inside with thick barium or with barium, and then we give gas, we give that double contrast effect, we can see things that are hanging out from the mucosal layer, like polyps or things like that, okay? So double contrast is for intrinsic things, single contrast, extrinsic, okay?
Oh, also another thing. Your front desk is the one who gives them the laxatives, tells them the instructions, tells them like they have to be on NPO, all these things. So once they come to your department, you still go through your list of like, okay, any past surgeries, are you NPO? A lot of the time they take NPO as just not like food, but then they'll take their medication with like a yogurt, and it's like, okay, hold on. So now we have to go ask the radiologist if they did this, you know what I mean? So you have to go through a questionnaire with them still.
And for order of operations, here's a pop quiz critical thinking question for you. If you had a patient who was going to get their entire GI tract evaluated with barium, would you do the upper GI small bowel follow through first and then the enema, or would you do the enema first and then have them come back to do the upper GI small bowel follow through?
I would say the bottom one, the second one you said, the bottom one, then just
Yeah, why?
I'm not sure why, but it just makes more sense.
Just to ensure
I think you are sure why.
Just to ensure that there's nothing else hanging out down
No.
there.
Good guess. Come on, April.
This is the
Dig deep.
The safety question. Why do we not do? We want to make sure that they have no other procedures before that.
Oh, to make sure that it's all clear.
Yes. So we do the enema first because it's the closest to the exit. If we do the small bowel first, then try to do the enema after, they're going to be full of barium. We are going to have to delay. Exactly. So we do the enema first, then the upper GI small bowel follow through.
This is a question on the ART.
Definitely. Okay, questions? Today's really easy peasy, guys. It's KUBs and obliques. Most of the day, you guys can practice that or just discuss where the contrast is going to be for the different positions. Okay? I'm not about trying to overwhelm you guys right now. And after you guys have practiced this for a little while, we will talk about the GU. Okay? So we'll give about 2 hours for this, and then we'll do the GU. Not too bad. And then tomorrow we'll do trauma, and then you guys can have Monday and Tuesday to practice.
I thought we were doing trauma next week.
I changed my mind.
I see, I knew it.
Because
Freaking knew it.
I like the idea of you guys having 2 days next week to practice.
Yes, I knew you were going to do it. That's why I started on my flashcards because I knew you were going to change your mind.
I'm always